Uh, Good evening, everyone. I'm sorry I have put all of you on mute. Uh, the reason being that there is a lot of disturbance in between if the presenter is not allowed to continue with his speech. So, as has been directed by the additional director, what we have decided is that we will mute everyone. We will allow only the speaker to talk. Whatever queries you have, please put it in the chat box. We will keep a note of it. And at the end of this session, we will be allowing all of you to interact with Dr. Manika Vasau. So let me first introduce Dr. Manika Vasau. He is the head of the CGHS Dental Wing, Safdarjung Hospital. And actually, this request had come in to us from all the doctors in the dispensaries because basically, as MBBS doctors, we do not have dentistry as a part of our curriculum. So obviously, we are not able to understand what dentistry is all about. So whatever requests or endorsements that we are forced to do in the wellness centers, half the things we do not understand. We find that multiple procedures are written at a particular time, and we are in a quandary whether to give those permissions or not. So because we received a lot of requests from the GDMOs, we thought let's discuss it with the dental surgeons of Safdarjung Hospital and ask them to make a presentation. We've already discussed those issues which commonly come to us from you. We shared it with the dental surgeons of Safdarjung Hospital, Dr. Manika Vasau in particular, and we requested him to make a PowerPoint presentation clarifying those issues. So I believe most of your queries will be clarified during the course of this webinar. And besides that, if you have any more queries, you can always put it in the chat box. So with that, I will hand it over to Dr. Manika Vasau and request him to start the webinar. Hello, Dr. Manika Vasau.
Hello. Hello.
Yes, Dr. Manika Vasau, we can hear you. You can take over from here, please.
Yeah, thank you so much, ma'am. Yeah, good afternoon, everyone. Yeah, I welcome all of you on behalf of the dental department, CGHS Wing Safdarjung Hospital. Yeah, we have been receiving a lot of queries regarding how dental procedures approved, written from an empaneled clinic should be approved. Actually, the queries have been like we don't able to make out a lot of treatment what they are actually, and even some queries like we are not able to make out what the tooth numberings are, how we are able to identify which tooth, what treatment they are going to be done. So it's just an attempt to recap what you will be already knowing. Many of you have attended dental posting during a medical course. So before starting with the dental treatment part, let me just start with the tooth notations. Yeah. Let me start with the tooth notation, how tooths are numbered actually. When you see any prescription that is coming to you for an approval dental procedures, there are mostly two types of notations, tooth notations that you commonly see there. One is called the Sigmondi or Palmer notation, and other is the FDA or two-digit system. Among these two, actually, the mostly 95% of the cases, you will be just seeing this Palmer notation system only. So you should be well aware of the system so that when a patient comes for approval, you can at least do some basic check. You won't be able to do a proper check. We need actually to need a mouth mirror probe and all. That won't be possible. Actually, you won't be having time also that, but maybe you can do some basic check actually. The other system is the two-digit system. The difference between the two is in Palmer notation system, actually, it is easy for visualization. Actually, you can just see there will be a plus sign and tooth numbers will be written on all the sides. Here it will be easily, you can visualize in which quadrant the tooth is present actually. But the problem with this Palmer notation is when you are trying to give a printout in a computer, we won't able to put that plus sign. So you go for a two-digit system there. But mostly prescriptions that you receive are handwritten and they are mostly in the Palmer notation system only. So I'll just tell you briefly what this Palmer notation and the two-digit system are. First, before knowing about Palmer notation, let me tell you how the plus sign, what does it indicate? Here you see a plus sign. This horizontal line actually divides the maxillary and mandibular teeth. See, imagine patient sitting in front of you and facing you. This imaginary line divides the maxillary and mandibular teeth. And again, this vertical line, which divides the maxilla and mandible into right and left half. So actually, the whole arch has been divided into 4 quadrants actually. This is the first quadrant. This is the second quadrant. This is the third quadrant. And this is the fourth quadrant. So maxillary right is the first quadrant. Maxillary left is the second quadrant. Mandibular left is the third quadrant. And mandibular right is the fourth quadrant. These quadrants are given in a clockwise direction. So once you know this, what is the meaning of the plus sign, then it's easier to identify the tooth actually. Here, this is what the Palmer notation is about. You see the plus sign. The plus sign indicates the maxillary and mandibular teeth, the horizontal line. Actually, the two numbering above this horizontal line are maxillary teeth. The numbers below this horizontal line are mandibular teeth. Again, this midline divides the maxillary mandibular into right and left half. So this is the first quadrant. In the first quadrant, you will be seeing numbers written as 1 to 8. Actually, you all be knowing there are 8 teeth in each quadrant. So there are total 32 teeth actually. This first number is the central incisor, and each tooth is represented by only a single number here. In the other notation, two-digit system, each tooth will be represented by 2 digits. Here in Palmer notation, each tooth is represented by a single number only. The 1 represents central incisor, 2 represents lateral incisor, 3 is the canine, 4 and 5 are together the premolars, first premolar and second premolar. 6, 7 and 8 are together the molars, first molar, second molar and third molar. Third molar is often also called the wisdom tooth. So you will be finding, so this numbering of the tooth starts from the midline actually. It starts from 1 to 8, and again from the second quadrant from 1 to 8, the third quadrant again 1 to 8, the fourth quadrant again 1 to 8. So total 32 teeth. Regarding primary, sometimes you may have prescription from pediatric patient also. There, to differentiate between the permanent teeth and secondary and the primary teeth, what they do is they don't give a number. Here, primary dentition is represented by capital letters A, B, C, D, E. There are only 5 teeth in each quadrant here. Here there are 8 teeth in each quadrant, 32 teeth. Here there are 5 teeth in each quadrant. Total there are 20 teeth. Here A represents the central incisor, B the lateral incisor, C the canine, and premolar is missing here. In permanent dentition, you have the premolars 4 and 5. Here you won't be having premolars. And even molars, there will be only 2 molars. There won't be 3 molars. So D and E. A represents central, B represents lateral incisor, C the canine, D first molar, and E second molar. So this is Palmer notation, and most of 95% of the prescription that you will be receiving will all have this plus sign and numbers written on all the quadrant. It depends on which tooth the treatment is required. That number will be present. 1 represents central, lateral, canine, premolars, and molars. And for a primary, this is A, B, C, D. Again, in some mixed dentition cases, you will find a plus sign. There will be numbers also. There will be alphabet also. So it means it's a mixed dentition case. If the child is between 6 to 13 years, sometimes there will be 1 also. There will be D also written. So you can make it out as a permanent dentition also present. Mixed deciduous tooth is also present. Primary teeth is also called as deciduous dentition or milk teeth, and permanent dentition is also called the secondary dentition. Then moving to the two-digit system, the advantages of this Palmer notation is that you have a plus sign, you can usually visualize the patient. Actually, the patient is sitting in front of you and is facing towards you. So when you see a quadrant, you can see it's a maxillary right, maxillary left, mandibular right. But the problem is you won't be able to give a printout. When you want to type it out something, you can't make a plus sign and give these numbers. That is the only disadvantage. Otherwise, this is the most commonly used notation for tooth numbering. Then comes the two-digit system. The advantage of this system is you can easily type it out. Just 2 numbers are written. The first digit designates the quadrant. We already know that the arch is divided into 4 quadrants, 1, 2, 3, and 4. So in the two-digit system, the first digit represents the quadrant. The 1 will be written, and the second digit represents the actual tooth in that quadrant. So for example, mandibular left first molar. We know this is the tooth below this horizontal line is the mandibular teeth, and this is the left side and this is the right side. So mandibular left first molar is written as 3-6. 3-6, where 3 represents the mandibular left quadrant and 6 represents the tooth, actual tooth. We know molars are 6, 7 and 8 are 3 molars. It's the first molar. Mandibular left first molar is written as 3-6, where 3 is the third quadrant and 6 is the first molar in that quadrant. Here it is any tooth you want, for example, if you want to mention about lateral incisor in the mandibular right quadrant, we can just write it as 4-2. If you want to mention canine in the maxillary first maxillary right quadrant, you can just write it as 1-3. First number digits the quadrant, the first digit, second digit will tell about the exact tooth. So these are the two notations that you commonly see in a dental prescription. One is the Palmar notation, another is the 2-digit system. See, for the 2-digit system, actually, here you see the 2-digit system. Here the plus sign. Here this plus sign is not written. It's just for understanding purpose. Here the tooths are written as in permanent, for a permanent dentition, a 2-digit system. It is written as 1, 1, 1, 2, 1, 3. The 1 represents the quadrant, and the second digit represents the tooth. 1, 1, 1, 2, 1, 3, 1, 4 to 1, 8. Again, for the maxillary left or upper left quadrant, it is written as it's a second quadrant, so it's 2, 1, 2, 2, 2, 3, 2, 2, 2, 8. Again, for the third quadrant, it is 3, 1, 2, 3, 8. Fourth quadrant, it is 4, 1, 2, 4, 8. This plus sign won't be there for a 2-digit system. Here it is given for representation purpose, just for understanding purpose. Again, for the primary dentition, what they do is here the tooth numbering is here we have in permanent dentition only 5 teeth each quadrant, so it is 1, 2, 3, and 4. Second digit represents the tooth actually. Whereas the quadrant number is here, since in the permanent dentition we have given the quadrant as 1, 2, 3, and 4. In primary dentition, the quadrants are given as 5, 6, 7, 8. Since 1, 2, 3, and 4 already taken, in primary dentition, the quadrant is mentioned as 5, 6, 7, 1. So when you see someone writing 5, 1 or 6, 1 or 6, 3, 7, 4, something like that, you can know it is a primary dentition. And the second digit represents the tooth. It is the fifth quadrant, it is the first teeth. Again, it's maxillary right side only, but it's a primary dentition. The sixth quadrant, this is the sixth quadrant, this is the seventh quadrant, this is the eighth quadrant. Tooth are again numbered as 5, 1 to 5, 5, 6, 1 to 6, 5, 7 into 7, 5, and 8, 1 to 8, 5. This is the maxillary right, this is maxillary left, mandibular left, and mandibular right. It's the same thing, only thing is the quadrant as mentioned as 5, 6, 7. Normally, you won't be seeing primary dentition, mainly it's permanent dentition, you should be remembering it's 1, 2, and 3, and 1 to 8, and 1 to 8, 2 to 8, and 2, 1 to 2, 8, 3, 1 to 3, 8, and 4, 1 to 4, 8. Now, just to know how it is written, actually, I have given 3 examples here. This is the maxillary right lateral incisor. Maxillary right lateral incisor, I have given both the notations here. This is the Palmar notation, and this is a 2-digit system. How it is written in both the system. For example, maxillary right lateral incisor. So a plus sign is in a Palmar notation, a plus sign is made. We know maxillary right is the first quadrant. This is the maxillary. Imagine patient sitting in front of you and facing you. This is the maxillary right. And then lateral incisor is number 2. Actually, central incisor is number 1, lateral incisor 2, canine is 3, 4 and 5 are premolars, and 6, 7, 8 are molars. So maxillary central incisor is written as a plus sign and a 2 here. Whereas if we go to a 2-digit system, we don't put a plus sign. The plus sign, instead of the plus sign, we just mention the quadrant. It is a first quadrant. So it's first quadrant, and the tooth is 2 here. So it's 1, 2. You won't call it 12, you call it as 1, 2. Another example, mandibular left second molar. If you have to write mandibular left second molar, you can know this is the tooth below the horizontal lines of mandibular teeth, and this is the left side of the mandible. So mandibular left, second molar is 7, first molar is 6, second molar is 7, third molar, this is the last molar is 8. So the plus sign and is 7 in the third quadrant, which is the mandibular left side. In a 2-digit system, it is written as just a 3, 7. We just mentioned the quadrant as 3 and the tooth number as 7. Another example is mandibular right canine. If you want to denote mandibular right canine, how it is in a Palmar notation, you see a plus sign, mandibular right, mandibular left. This is the mandibular right. In this quadrant, it is a third number tooth. It is easily visualized. Mostly in the prescription, you'll be seeing only this Palmer notation. It will be written like a plus sign. Mandibular right canine is written as a plus sign. Mandibular right quadrant, third number 2. In a 2-digit system, it is written as 4-3. Since this is a quadrant 4, it is written as 4 and a 3. For example, if this is a pediatric patient, here again the quadrant won't be 4 here. Actually, in pediatric patient, the quadrant will be 5, 6, 7, and 8. So it will be 8, 3 if it is a deciduous dentition. But mostly you won't be seeing. You can just remember about the permanent dentition. That should be enough. Now regarding certain procedures, actually, I have many times heard that there are a lot of procedures repeatedly being advised, and we don't know exactly what these procedures are. So I just thought I'll just give you a idea about what this procedure are. Maybe you can have just next time when you see them, you can just have some idea what they are. Mostly among the approved procedure, dental procedures, these are the 6 procedures which is most commonly written. And most commonly written for multiple reasons, but we have to be just knowing what they are so that you can approve them or not. So if you find some difficulty or some, if you find some clinics are repeatedly asking for permission for certain procedures repeatedly, you can make it out whether they're actually doing those procedures. You can have an idea. First one is a flap surgery, and the other one is a gingivectomy. The third one, these 6 procedures I found mostly there has been query about what these procedures are. So I just thought I will just mention about I'll tell them about them. Flap surgery, gingivectomy, these both are periodontal surgical procedures. I'll tell you briefly what they are. Flap surgery, gingivectomy, and then we find alveoloplasty and ridge augmentation. Again, these 2 procedures are repeatedly written in prescriptions. Alveoloplasty and ridge augmentation. These 2 procedures are pre-prosthetic procedures. Before actually a patient has got his tooth extracted and he wants to go for a denture. Before going for a denture, actually we check whether his bone is smooth, even there is no rough edges, there is no irregular margins, something like that. We just do a we just reshape the bone. That is called the alveoloplasty. Means alveolar bone reshaping of this alveolar bone. Alveolar bone is the bone which holds the tooth actually. So it's a regularly done procedure, alveoloplasty. Then there is a ridge augmentation. Ridge augmentation is actually strengthening the ridge. Sometimes if a patient wants to go for an implant procedure, something like that, even for a denture, actually if you find the ridge is not, there is a deficiency in the ridge, you want the thickness of the ridge is not there, the height is not there, just you strengthen the ridge by using a bone graft procedure. So ridge augmentation, alveoloplasty together are pre-prosthetic prosthetic surgical procedures. And this is episectomy. Episectomy is you just remove the tip of the apex. Actually, every tooth has a root, and the tip of the root is called the apex. When the infection goes beyond the root and involves the bone, actually what we do is we remove the infected material from the infected tissues from the periapical region, and then we resect the bone or the tip of the root also. It's called the episectomy. That is removing the apex of the tooth. And then finally the night guard procedure. Night guard is the last one is a night guard. Night guard is actually not indicated for everyone. Only patients who are having problem of grinding of teeth during the night time or clenching of teeth, they actually have a severe attrition of the teeth and they need this night guard. But it is actually misused a lot of time. For everyone, you find a night guard being written. Night guard everyone can wear actually. It isn't that easy to wear something and sleep at night. So it has to be seen whether the patient actually requires a night guard. I'll just briefly tell you some pictures also so that you can make it out how it looks like. First about flap surgery. What is flap surgery? Flap surgery actually is it cleans the root of the tooth and repairs the bone damage caused by gum disease. Actually, initially, when someone is not keeping his oral hygiene clean, initially it starts with a gum disease. When you don't take care, actually the gum disease progresses and actually involves the bone surrounding the tooth, and it erodes the bone, and there is a deep pocket formed in between the teeth actually. This flap surgery actually helps in eliminating that pocket. You just raise the flap, clean the root surface, and then suture it back. This is actually a little bit needs some skill, and it is not routinely done in clinics actually. It's not. I'm not saying it is not done, but you have to be thoughtful whether this can be approved, because this procedure is routinely. It needs skill and time, and the patient needs to be explained before doing this procedure. But many a time when the patient comes with the prescription, and if you ask them what is this, they will be saying, I don't know, doctor just advised it. That means they are not going to do that procedure. If you are going to do this procedure, you will actually have to prepare the patient. You should tell there will be an injection, there will be surgery for at least half an hour to 1 hour. Post surgery, there will be suturing done, and there will be pain, swelling for another 1-2 weeks. So all this happens. So you can't do this procedure just like that. So, but many a times we see frequently patient coming with such procedure. You have to be a little bit aware of what they're doing. Again, regarding flap surgery, this is what happens actually. This is the health picture of a healthy teeth, and here you see, because of poor oral hygiene, actually you see the gingiva is pulled away from the teeth. There is space between the teeth. That is actually, it's called pocketing actually. And only in these conditions where there is severe bone loss, interdental pocket, we do this flap surgery. As here also we can see a molar here, a premolar here. It's a cross-sectional view. Here you see the bone height between the two teeth. It's till this level, and the gums, you can see the interdental gums actually. There is no space in between teeth. But due to periodontal problem, what happens is the bone level recedes, and the gums which are attached over the bone, you see they are inflamed, and there is enough interdental space here. This space would gets impacted, and this is called the pocket. To eliminate this, we actually do this flap surgery procedure. So patient should actually have some necessity for the procedure. This is a picture for understanding flap surgery procedure. Here you can see the gingival recession here and a little bit gap in between teeth. Patient complains of chronic dull pain, foot impaction regularly over here. See the surgical where the flap is raised from maxillary right side canine to the maxillary left side canine. And you can see this is the root of the tooth actually. Actually, the root is exposed here. Actually, the bone should be up to this level actually. Here, the bone level has receded very much. There is pocketing all over, foot impaction regularly happening here. So in such cases, the flap is raised, the bone debridement, the infected tissue is removed. After cleaning, suturing is done back. So this is actually the picture for a flap surgery. Again, flap surgery in an anterior teeth. This is the lower mandibular teeth, central incisors. Again, you can see the poor oral hygiene here. Here the bone. So you can see the gingival recession here. You can see the gingival attachment at this level, and here it has come down because of poor oral hygiene. Again, you do a flap surgery here, and post surgery. This is the picture. Then what is gingivectomy? This is again one more procedure you can routinely come across. Gingivectomy is total removal of a portion of your gums in and around around one or more teeth. Actually, it is removing a portion of the gums. When is gingivectomy done? It is actually done when there is again deep pockets, just like flap surgery you say. Here also gingivectomy is done sometimes when there is deep pocket. When there is gingival enlargement. Gingival enlargement happens in any inflammatory condition, even after some medications like patient taking medicine for seizures like phenytoin, cyclosporin, phenidipine, they all cause gingival enlargement. There you just resect the portion of the gums in total. Again, sometimes to increase the crown height. Sometimes patient will need a crown, but the tooth height will be very less. If you make a crown for that tooth, it won't stick actually, it come out often. So you have to increase the crown height, and for that you just remove the gums which are surrounding the tooth little bit so that the height of the crown is increased. And sometimes even for aesthetic reasons, even some people they will have a gum attachment which is more than the normal. So you just remove a little bit of the gums, and for aesthetic reason, the anterior region of maxilla. This is a picture for gingival enlargement. This is how gingival enlargement looks like. If gingival enlargement looks like, and this is post-surgical after gingivectomy has been done. Again, it's like lower mandibular teeth. Here you can see the gingival enlargement here. You just measure the depth of the gingival enlargement, and just with the inclined blade, just remove the you do a gingivectomy. Then bone debridement is done with the burr, with the bone ranger and all. And finally, after procedure, you give a periodontal dressing over. It's a dressing, medicated dressing. On post dressing, this is how it will look like. Now, it was initially like this, then post dressing, it looks like this. Here, for aesthetic reason, some gingivectomy has been done. You can see the gingival covering the tooth here. Post gingivectomy, you can see the increased height of the tooth. For even for aesthetic purpose, it looks good. It is gingivectomy done for an aesthetic reason. Sometimes following orthodontic treatment, patient has been wearing braces for 1 year, 1.5 years. After that, they are not able to keep the oral hygiene properly. They have gingival enlargement like this, and they too need gingivectomy. It is done. Here it is done through a laser. Even you can do it manual. Then what is alveoloplasty? Alveoloplasty, as I told you, it is the reshaping of the alveolar bone. A surgical procedure that reshapes or smooths out the alveolar bone, where tooth or teeth has been extracted or lost. A patient has got his tooth extracted. Immediately you can do alveoloplasty. Sometimes you extract the tooth and you recall them after some time for an alveoloplasty. It is just removing the sharp edges, bony prominence, and undercuts prior to any prosthetic rehabilitation. Before going for a denture or implant something, you do an alveoloplasty. The degree of bone abnormality will indicate the most effective method of alveoloplasty. Regarding alveolar, here again alveoloplasty is done. You see the bone level here. It is because of missing low mandibular teeth. The tooth supra-eruption of the maxillary teeth has happened. After removing the teeth, just to give a denture for this patient, you do a alveoloplasty. You just reshape the bone here, so that patient go for a denture. Again, this is a picture for alveoloplasty. Here, patient is an edentulous patient. It's a geriatric patient. He has got all his tooth removed. But if you see the bony margin, they are not uniform. They are actually zigzag. Actually, it is bony prominence here. There is undercuts here. You can't go for a denture in this case. Before going for a denture, you have got a alveoloplasty done. You raise the flap. You just remove these bony undercuts. You smoothen out so that he has a uniform bony margin, so that there will be a snug fit. Otherwise, the denture won't fit properly. There will be food getting accumulated underside of the denture, and patient won't be able to eat properly. So before going for a denture, you do an alveoloplasty, and then you go for a denture. Another procedure which is often advised is ridge augmentation. As it is said, ridge augmentation is strengthening of the ridge. Actually, where you before going for a prosthesis, sometimes you find that the ridge thickness is not there. It has eroded over a period of the patient has got his tooth extracted a long time back, and the ridge level is low or it is thinned out. To increase the width and height of the ridge, you do a ridge augmentation procedure. It is increase in the it is to increase in the volume of the deficient site for implant treatment. This is a picture for ridge augmentation. You can see the cross-sectional view of the ridge. It is thinned out here. You do a bone grafting, and then you can go for a implant like this. So otherwise you won't be placed an implant in this tooth. So ridge augmentation is a specialized procedure. This is not done routinely in a dental clinic setup. So if someone is asking for ridge augmentation procedure frequently, routinely for all patients, you have to be a little bit thoughtful. This is a picture for ridge augmentation. You can see the occlusal view. And this is a premolar, the second molar, the first molar has been extracted a long time back. So the ridge has thinned out. After the ridge augmentation, you can find the thickness of the is increased, and you can go for a denture. And finally, a night guard. Many a times we find patient asked for a night guard. Night guard is nothing but a retainer-like appliance which covers the biting surface of the teeth and can be worn on either maxillary or mandibular teeth. It's also called a splint. Actually, when patient complains of bruxism. Bruxism is nothing but clicking and popping sound during mouth opening. Early morning when the patient gets up, he will have tooth pain or jaw soreness. There will be people who are sleeping with them will say that they keep on grinding their teeth, they are clenching their teeth very hard when they are sleeping. Only in such cases, night guard should be advised. They are custom made for each patient. The impression is taken and they get it done from a lab. This is also called as splint or mouth guard or occlusal guard. It is called by several names. This is a typical case where a night guard can be advised. You can see the patient who is doing severe grinding of teeth and clenching of teeth. This is how this tooth will look like. There will be generalized attrition of teeth. There is severe attrition of teeth. In such cases, night guard will be useful. This is another picture for bruxism. You can see the upper maxillary teeth. They are literally arteriated up to the gums level. This is a healthy tooth, another teeth which has been affected by bruxism. There will be attrition, there will be abrasion, there will be gingival recession. All this will be seen in a patient of bruxism. This is a picture for night guard actually. Here the picture is it's made up of acrylic material. It's a plastic-like material. What we do in CGHS is the pink color one. It is very hard actually. This one is little bit softer and it is a clear acrylic. Actually, you can even wear it in the daytime. This one. This is how it is worn. You can see the night guard being worn in the upper maxillary teeth. It is worn either in the maxillary teeth or in the mandibular teeth, not on both sides. Then episectomy. Finally, what is episectomy? Episectomy is an endodontic surgery post RCT. It is done. Actually, when your teeth is infected and is coughing and is causing pain, you actually do an RCT. Post RCT, sometimes post RCT you won't be able to fully, when you are not able to fully remove all the infected tissue, there is a small periapical lesion that occurs in the tip of the tooth. In such tooth, what we do is you do a surgical procedure, remove the periapical infected tissue, and then also resect the tip of the tooth. It solves the problem by removing the apex along with the surrounding damaged teeth. I'll just show you an example for episectomy. This is how episectomy is. Here it's a normal tooth. Here the tooth has a caries in this crown part. It's actually enamel is the enamel of the crown of the tooth, which is involved. At this stage, you can do a restoration. Simple restoration will do. Again, you can see when you don't treat the caries in the enamel, then it progresses to the dentine. Even at this stage, you can go for a restoration. But once you don't manage here, then it involves the pulp. Only at this stage, the patient complains of severe pain. You do an RCT here. Even if you don't do an RCT at this stage, this actually it's necrosed. Actually, the pulpal material fully get necrosed, and slowly the lesion gets extending to the bone. Actually, it extends to the bone surrounding the tooth. Actually, here you form a infected tissue around the. It's called the periapic infection in the periapical area around the tooth. Actually, only in such cases, what we do is you do an RCT. If the periapical lesion is of a smaller lesion, we wait and see whether it resolves on its own. In case if the periapical lesion is a bigger one, it's not resolving on its own, we actually do a surgery. We just raise a flap here. You just enter through the bone to the periapical region. We remove this infected material, and we also just resect the tip of the root is a little bit resected here, and you do a retrograde filling also. Restoration is also done retrograde. This is a picture for episectomy. Here you can see in this case actually this maxillary left side is actually, you can see the quadrant here. This is a maxillary right. This is a maxillary left. On the maxillary left side, you can see the first and second molars, first and second incisors. They are actually infected. This is an occlusal X-ray. In the occlusal X-ray, you can see a periapical lesion here. This is the central incisor. This is a lateral incisor. This is seen from the palatal view. Actually, this is a palatal view. This is a frontal view. So a lesion is seen here. You raise the flap. You reach the tip of the tooth. You can see the tip of the tooth here. You reach the tip of the tooth. You clean the whole area. Remove the infected material. You debride the area, and then you switch it back. Post episectomy, this is how it looks like. So episectomy again is a skillful procedure. Everyone won't be doing it in a clinical setup. So if someone is asking for episectomy for multiple teeth, that too for posterior teeth, you have to either consult, you have to refer the patient to a dental surgeon for opinion whether it's required as such. This is again a picture for episectomy. You can see the we can see a canine and a lateral incisor here. There is a periapical lesion. Episectomy has been done, and the root tip has been resected. The root tip is resected here. This is a picture for episectomy. Now I'll just come to some frequently asked questions. Many a time I have been told that permission is asked for multiple dental procedures at one go. Is it advisable to give permission for multiple by one go? I would say yes. If the patient requires multiple procedures, you can give approval for that. There is nothing wrong there. Sometimes because in India, most of the patients, they don't go for a regular dental checkup. So only when they have some problem, they visit a dental, they visit a dentist. So only at the time they come to know they have multiple other problems. So if they are asking for permission for multiple dental procedures, it can be given. There is nothing wrong in that. This again is similar to that problem in one teeth, but multiple procedures are advised. Actually, patient to India visit dentist only when they have tooth pain. So only when you get a complete oral checkup done during that period, you come to know that they have restorations to be done in other teeth, then they need to be scaling need to be done. All this we find out. So multiple, they may be going for only one problem. It will be they will take care of that problem initially, but they may also need to get their other problems solved. So if multiple procedures are advised, permission can be given if they are required those treatments. And in prescriptions, have all investigations and procedures in one go. Mostly investigations from the dental side will be an X-ray. Most commonly it is an IOP X-ray or OPG X-ray. OPG is the full mouth X-ray, orthopentagraph. It's a full mouth X-ray. Generally, when a patient comes for the first time, you just get a full mouth X-ray to have a complete oral examination. Then you have a better idea of all these conditions. So OPG is done. IOP is mostly a chair side X-ray. When you are doing some procedures like RCT something, you may have to do an IOPA to know exactly whether you're doing it right. So even for one RCT, you may need to do at least 3 IOP X-rays, pre-operative, post-operative, and even during the RCT procedure, just to be sure that since it is an indirect procedure, you just need a help of an X-ray. So multiple IOP X-rays will be advised. I think that should be okay. Regarding procedures, there are some procedures which are most commonly needed by all patients. So I think there shouldn't be any problem giving approval for such procedure. For example, scaling. Many people will be requiring scaling, cleaning of the teeth, scaling of the teeth. Restorations, people will require restorations or fillings of the teeth. Extractions may be required. RCT may be required, root canal treatment. And post RCT, people may require crown also for them. You have to make a crown for them. So these procedures are generally common procedures and permission can be given for them, and routinely there is nothing wrong with that. Only when it comes to flap surgery, gingivectomy, alveoloplasty, ridge augmentation, episectomy, these procedures, one has to be little bit more thoughtful whether these procedures are very much required. You can even ask the patient. Patient itself many times says that the doctor, either he will say he didn't know what it is, or he will say the doctor advised it just because CGHS rates are low, just to make them pay less. This procedure is added. They themselves say that actually, so you can easily make out whether these procedures are required. Another FAQ is that regarding numbering of teeth. It is said that there is a prescription where it was written treatment needed in RCT4 metal crown 4. What is this? Actually, this is not the right way to write. RCT4 only means you need RCT in 4 teeth. It doesn't represent any tooth actually. But before giving approval for any procedure, they have to clearly mention the tooth, whether it is extraction, whether it is restoration or anything. The tooth number should be clearly written, whether it is in the Palmer notation or the 2-digit system. You can't write like RCT4 metal crown 4. That means you need RCT in 4 teeth. What are those teeth? No one knows. So permission shouldn't be given in such cases. They should have to clearly mention what are those 4 teeth in which RCT is needed, metal crown is needed. Again, there was like a prescription where it was 10 RCTs, advice for 10 RCTs, 18 metal crowns, episectomy, ridge augmentation, flap surgery, everything was advised here. I think it doesn't look like a proper thing. It is more suspicious actually. In such cases, you have to refer to a dental surgeon so that it will be better. We can examine and tell whether these are required or not, because you don't do episectomy. They do episectomy in multiple teeth. They ask for a posterior. Even doing episectomy anterior teeth requires a lot of skill. I don't think in a clinical setup it is that much easier for everyone to do episectomy in multiple teeth, ridge augmentation, flap surgery, all these things. These cases should be referred to dental surgeon for their opinion. Another one query is that multiple RCTs are advised in multiple quadrant. Is it possible to do them in one sitting? I don't think no one is saying that they can be done in one sitting. Actually, that RCTs may be required in multiple quadrant. Permission is taken, but they will be doing it only one by one. Sometimes if in a particular quadrant, if there are 2 or 3 adjacent teeth, you can do them together. For example, in a third quadrant, if 2 premolars are requiring treatment, you can do them together. But if you are going to open one tooth on the left side and one tooth on the right side, it won't be the right thing to do because patient has to eat from one side. So mostly they usually finish the procedures on one side of the tooth, whether the left side or the right side, and then they move to the other side. So permission can be given for multiple RCTs, but they're not going to be done in one sitting. They will be done in multiple sittings. There was someone asking whether illegible handwriting, no name in the prescription, dental opinion referral. No name in the prescription, then you don't give, I don't think approval is given. And actually, they should have mentioned their name and signature and stamp actually. As far as illegible handwriting, I think you will be knowing better. That actually, you can always ask for them to come back with the proper prescription. Again, now let me just conclude actually. Here, one of the reason I often hear is that CGHS rate list for dental practices is the rate is very low actually. So it is one of the reason why many empaneled clinics they actually write these procedures which they won't be doing just to make sure tell the patient that you will be paying less if you get approval for this procedure also. Even the patient knows these procedures are not going to be done. So I think there is a need to revise this rate list. Actually, it is very low at present. You can see they are giving 100 rupees for a tooth extraction. I think these days it is done for 100 rupees. I think there is need for a revision. Even the CGHS rate list for dental procedures for Bombay, it's very high. It's quite good actually. For Delhi, this rate list and these rates are very low. They should be revised. And I think there are also need for add more dental treatments to the existing list. For example, implants is not in the list actually. So many CGHS beneficiaries actually they pay more money to get their implant done. Sometimes it's very much required for a young patient who has got just lost one teeth. He can't go for a crown and bridge to replace his tooth. They have to go for an implant. So some implants, procedure like implant, and there are a lot of other procedures which needs to be added to the existing list. And third, I think whenever any medical officer finds it's not able to understand what the procedure, what has been advised, I think it's better that they refer it to a dental surgeon at CGHS. And there are some 10 dental surgeons in Delhi actually. I think we can actually designate 3 or 4 dental surgeons for each zone as nodal officers, and they can actually approve these procedures. Either you can refer them through mail, or they can even visit your headquarters, zone headquarters, maybe on a weekly basis, something like that, and then approve. In case maybe at the referral stage there is no problem, but at approval stage, I think dental surgeon should be involved when and where you find there difficulty. Because if you are going to approve procedure without knowing what it is, actually it is harming the patient. They are going to get unnecessary treatment, and it is not our aim actually. So I feel that whenever possible, you should refer them to dental surgeon for approval. Thank you. If you have got any.
Yes, Dr. Manika sir,
Yes,
thank you so much. That was a very informative tutorial that you gave us on the common dental procedures. And since you based your PowerPoint on the common queries, I'm sure a lot of queries have been clarified. One by one, I think our participants can now unmute yourself. And if there are any queries, you can either put it in the chat box or you can directly talk to Dr. Manika sir. Anyone has any queries? Please unmute yourself before you talk.
Good evening, sir. I am Dr. Sai Kiran from Jabalpur.
Good evening, Bhash.
Sir, it is told that when RCT is advised, the X-ray is included in the RCT rate. Is it correct, sir, or we have to give a separate referral for both?
No, whenever you do an RCT, X-ray is a must. So sometimes what happens is we just advise RCT, and when the implant clinic does the treatment, they include X-rays as part of the RCTs. Or you can also give permission for an X-ray. So it can be done both ways, but usually we only give permission for RCTs. But when they make a bill, they include X-rays also in that, because X-ray is a must. And per RCT, you can include at least 3 IOP X-rays.
So they can do that, sir, but we need not give the referral.
No, you just give approval for RCTs. When they make a bill, they include X-rays in that, because X-ray is part of the RCT. Because without X-rays, you can't do an RCT.
But the package rate doesn't include the X-ray, but they can claim IOPA with the RCT.
Yeah, actually it should include RCT should include X-ray, because without X-ray, RCT is an indirect procedure. So without X-ray, you won't be able to do it. You need a post-op, pre-op, and IOP X-ray during the procedure to know the exact working length of the tooth, whether you're able to clean the whole tooth properly. So 3 IOP X-rays for each RCT is you can allow actually, but it's not in the list, so they always make it. They ask for it in the bill actually.
Yes, sir. Okay, sir.
So thank you.
Thanks.
Any other query?
Namaskar, Dr. Ramana this side from Bangalore. I just wanted a common error which people have. They don't really know what is the notation for the quadrants, how it is written.
Okay.
In earlier thing, we used to have a grid, a plus mark with 1, 2, 3, 4, 6, 7, 8 like that.
Yes, sir.
Nowadays we are writing 1, 7, 3, 2 and something like that. It's a little confusing. Could you explain that?
Yeah, I just now explained, sir. Actually, there are 2 types of tooth notation, sir. One, what you said, the plus sign is the Palmer notation, and the other one, what you told, the 2 numbers are written, is actually the 2-digit system. In the 2-digit system, actually, the first digit represents the quadrants, sir. Actually, the whole jaw is divided into 4 quadrants. And it is like, imagine patient sitting in front of you, facing you. The maxillary right side is the first quadrant. Maxillary left side is the second quadrant, mandibular left is the third quadrant, and mandibular right is the fourth quadrant. It's a clockwise actually. So
good.
In a 2-digit system, if there's someone is saying I want to do RCT in tooth number 1, 7, it means it's the first quadrant, tooth number 7. Tooth number 7 is the second molar actually. 6 is the first molar, 7 second molar, and 8 is the third molar. So if 1, 7 means it's the maxillary right side, second molar. If someone
Dr.
is saying,
Manikawal sir, would it be possible for you to share that PowerPoint
yeah, I can once again show that.
slide once again? I think it'll be clear.
Yes, I'll just show the slides again.
And thank you, sir, clarifying regarding the X-rays. I mean, should we note that 3 X-rays per tooth or something, IOP X-ray per tooth allowed when we're giving a reference for RCT?
No, you can just
because sometimes especially the departments, when they are passing a bill, they only pass for the RCT. They say X-ray not allowed.
No, sir.
There's always a confusion. The patient ends up losing.
Sir. Actually, if you want, you can give a permission for X-rays also, sir. Because X-ray is part of the RCT. Without X-rays, you can't do RCT, sir. So,
that's why.
Yeah. From your side, you can always advise.
It's safer. Yeah. Thank you.
Yeah. So this is the. So this you asked about the tooth notation. I told you.
Excellent. Thank you. This image, I think we should share it.
Yeah,
it will help everybody.
Yeah, this is the Palmer notation, sir. Actually, it is divided into 4. The jaw is divided into 4 quadrants: 1, 2, and 3, and 4. So this is the first quadrant, maxillary right. Mandibular maxillary left is the second quadrant. Mandibular left is the third quadrant, and mandibular right is the fourth quadrant.
Okay. Thank you.
So when you mention a plus sign and the tooth number mentioned it this way, you can just make it out. It's the right maxillary right.
This one I'm familiar with. The new one is coming. It's a little confusing. Yeah.
Okay. Actually, this is the most common one. So this plus sign and that mentioning the number of the tooth is the common one. What you said, the other one is the 2-digit system. Here you just mentioned the first digit is the quadrant number.
Yes.
And the second digit is the tooth numbers actually. In the first quadrant, if you are going to do an premolar 4, it is 1. It is not 1, 4. So first quadrant 1, 4. In third quadrant, if it is going on a canine, it is 3, 3. Third quadrant, third tooth is a canine. So it's a 2-digit system. You just mention the quadrant first and the tooth number first. Thank you, sir.
Thank you. Thank you so much.
Thank you, sir.
Dr. Manikawal sir, there is a query coming in. Is crown a part of the RCT treatment?
No, ma'am. Crown is not part of RCT treatment. It is usually advised to post RCT. Actually, post RCT, you are supposed to see the post-operative X-ray. Actually, if the X-ray comes good, if the RCT is okay, then you advise for a crown. Mostly these days, you advise crown for RCT, but still, it is not part. It is not given simultaneously. Actually, post RCT, you have to examine whether they got the RCT is done properly, and then you give for a crown. What initially sometimes we give for the approval for crown also together with RCT, but what happens is sometimes RCT is not done properly, but they get the crown also. Later they come and say that we are having pain now, but we can't do anything. Already the crown has been placed, so it's mostly RCT first and then crown. But sometimes for convenience purpose, maybe for a geriatric patient, something like that, we give permission for both together also. It depends. But it's not, they are not together actually. They are separate procedures.
Sir,
So there is another query.
Sir.
What is the difference between extraction of anterior tooth and posterior tooth, because they have separate CGHS codes?
Anterior tooth, actually a tooth, ma'am, I told you there are tooth, they're numbered from 1 to 8. 1, 2, and 3, that is central incisor, lateral incisor, and canine. The three together are called the anterior tooth. Premolars and molars, there are 2 premolars and 3 molars. These 5 teeth together are called the posterior tooth. So anterior tooth is 3 on each quadrant and posterior tooth is 5 on each quadrant. This is maxillary right side, 3 anterior teeth, and this 4 posterior tooth, and it's for all the quadrant, it is 3 anterior teeth and 4 and 5 posterior teeth. Central, lateral, and canine are called the anterior tooth. Premolars and molars are posterior tooth. So someone is saying, I need extraction in anterior tooth. Actually, they have to mention which anterior tooth. They can't just say I have been RCT in anterior tooth, permission for anterior RCT in a posterior tooth. They can't ask like that. They have to mention which posterior tooth they need an RCT to be done, which anterior tooth they need an extraction to be done. Each tooth has to be mentioned because this should be on record. Because later you don't know whether they are doing procedure for the same tooth multiple times. So each tooth they have to mention which tooth they are doing the procedure. Whether it's anterior tooth means which anterior tooth. But anterior tooth is central incisor, lateral incisor, and canine. Posterior tooth is premolars and molars.
If I may contribute, the
Yes,
anterior RCTs are easier because they are accessible easily. The
Yes, sir.
posteriors require more complexity in the procedure. The angulations are different.
Sure,
So it's
sir,
more
sure.
complex, so it's costlier. Yes, sir,
Yes,
I
sir.
agree. Thank you.
Yes, you are right, sir.
Sir, excuse me, I'm Dr. Anil Kumar
Yes, sir, welcome, sir.
from Palam CGHS Delhi. Sir,
Yes,
how many RCTs in a one go we can endorse?
Sir, you can endorse as number of RCTs they are asking for, but the thing is, there should be a requirement for that. They won't be doing all the RCTs in one sitting, sir. Actually, patient may require in the mandibular, mandibular left side, they may need RCT in 3 teeth. In the mandibular maxillary right side, they may be requiring in 2 teeth. Permission is usually taken at one go, but they usually do one by one, sir. If the tooth are adjacent, they may do 2 or 3 tooth simultaneously RCT. If they are in separate quadrants, they won't be taken up simultaneously, but they'll be doing one by one. But permission can be given, sir. They're asking RCT permission for multiple teeth, permission can be given.
Sir, what usually happens is sometimes when we give combined permissions, then they are not actually RCT being a procedure, it is valid for a period of 90 days. And when we give combined permission for several RCTs at one go, then sometimes what happens is in that time period, they are not able to complete all those RCTs. And then they come back to us saying that this time period validity is over. Now, please give us the permission again.
Yes,
It's very difficult for us to know which are those teeth for which RCT has already been done. It's very complicated then. So I think that's where the query is coming in from, that how many can we give actually or at a time?
Ma'am, it's nothing like that. We can give only for 1 RCT, 3 RCT, nothing like that. Even if for 5 RCTs, you can give permission. Ma'am. Sometimes 1 RCT may take more time. They might be able to complete within that duration. But asking them to come back after every RCT, after every 2 RCTs, it is also again not going to be right. It will be again harassment. Patient will be coming to you often for same thing. I think you can give permission. I don't think they should be asked to come back after 2 RCTs, after 3 RCTs like that. You can ask them to come back. Sometimes if the 2 RCTs are adjacent to, maybe they can do it faster. So permission can be given for multiple RCTs. There is nothing like there is no defined like we can give permission for in one go for 2 RCTs, 3 RCTs, nothing like that.
Okay. Any more queries?
Sir, I have got a query. I'm Dr. Prasanna from Bangalore.
Yes,
In the new referral system, we are not able to mention the put the what do you call plus mark and put the kind of teeth which we has to be replaced or treated. So can we put just the number of teeth which has to be treated?
No,
Say,
no,
for
sir.
example, they say in the mandibular teeth, right side 1, 2, 3, 4. I mean,
Yes, sir. Yes, sir.
can we put just 4 teeth? Because in the new referral system, we cannot put the mark and note the teeth.
No, sir, but it's always advisable to give approval only when the tooth are mentioned. So it's actually, it will be the right procedure, sir. Actually, you should know which tooth the procedure is being done. Today they will say mandibular. I am getting RCT done in mandibular 3 teeth. Again, maybe after 3 months, they will say I am getting RCT in another 3 teeth. Which teeth? How will you know, sir? If they had mentioned they are getting treatment in 1, 2, and 3. Next time, if you're thinking the mandibular left side or right side, you can easily make out which teeth they are getting a treatment. Otherwise, they should mention the teeth. Even for extraction, it's very important. You should know which tooth they are getting it extracted. You can't just mention I'm getting an anterior tooth extracted, posterior tooth extracted. Posterior, there are 5 teeth. Which teeth they are getting extracted, that should be known, sir. Even for patient purpose, it will be for
Agreed.
legal purpose.
May I contribute, sir? I think we should give the dual digit code, sir.
Yes.
Say,
yes.
say 2126 25 whatever.
Yeah, it's
So,
easier.
and that can be marked in that remarks column. We may not be able to put the plus mark.
Yeah. 2G system is easier to actually type in printout or type.
It makes sense now. It makes sense. It makes sense
yes.
now.
Yes, sir. 2D system can be followed. It's easier actually. Also.
Okay, thank you.
Thank you.
Any more queries from anyone? Dr. Manikova, so maybe you
Yes,
can
sir.
give us some tips about how to take care of the teeth also, because that also is an important part that we need to advise to our patients so that they don't get into this trouble of having multiple RCTs done.
Yeah, again, one of the reason why people are getting permission for multiple teeth is they are not maintaining the oral hygiene properly and they're not getting checkup also regularly. Actually, dental checkup should be done at least once a year, ma'am. In India, we don't have the system. Actually, they go to your dentist only when they have pain. That's why only at that time they come to know that they need to get restored in 3 or 4 teeth. RCT should be done in another teeth. All those problems is because of regular checkup. The regular checkup should be even after getting all your teeth restored. Still, you should get a regular checkup to know whether your restorations are intact. They need to be refilled again. So regular checkup is a must. Other than that, personal oral hygiene, I would say brushing twice a day, soft gentle brushing twice a day at least. Every time you eat something, gargling. After 40, maybe you should start doing flossing. And people who have got metal crowns, actually they should start doing flossing sincerely, because many a times after having this crown, they complain of food impaction. Actually, after having a crown, they should be told to start doing flossing, because how the contact between a two natural teeth is different from what the contact between artificial teeth and natural teeth. So you should start doing flossing post crown and bridge. Any process you have got, you start doing flossing, and regular checkup should be done.
So, any more queries from
Good
anyone
afternoon,
else?
sir.
Good afternoon.
Good afternoon, sir. This is Dr. Deepak from CGHS Bangalore. Sir, re-RCT, is it included under CGHS release, sir? Because sometimes they mention like it is uncoded procedure.
Actually, one way what we do is actually when a patient comes with pain and RCT treated tooth, we just mention it's an incomplete RCT. If the RCT is not proper, we just mentioned as incomplete obturation. Yeah, if there is any periapical lesion, we mention that, and again we advise for an RCT. But actually, it should be included. Re-RCT should be separately included as a procedure. That would be more easier actually. At the moment, we don't have that. But
So currently it is uncoded procedure only, right?
yeah, it's but you can just mention it. But if you want to get a RCT, you can't write it as RCT. You can just RCT, but in the bracket you can just mention it as RCT already done, and the RCT is incomplete. It may be incomplete, not proper. Yeah, if you see an X-ray, you can make out whether it is incomplete. We call it as obturation. Whether the filling is not proper, we call it as incomplete obturation. We just mention it as incomplete obturation, and patient needs to go again for an RCT. We just mention it like that. We don't mention the word re-RCT. Sometimes it creates problem for patients actually. But it should be separately. There should be a coding also for re-RCT.
Okay, thank you, sir.
So Dr. Manikova, so you think in re-RCT cases, an opinion should be taken?
Yes, ma'am. No, re-RCT cases, whether opinion can be taken just to know whether the re-RCT will be successful. Sometimes, mostly after re-RCT is not an easy thing. Actually, RCT the first time it should be done properly. Re-RCT, mostly the prognosis actually comes down a little bit. It's you can't give a guarantee unless otherwise it's done by a endodontist who is. Some people find it difficult even to remove that old RCT. The filling that you have done in the old RCT, remove it, people find it difficult. So only endodontist who is quite experienced can do a re-RCT and give some assurance. So the prognosis after a re-RCT is actually comes down. Actually, getting approval from a dental surgeon will be more better. Actually, they can know whether re-RCT is possible in that particular tooth, whether there is any periapical lesion, how it is. You can just tell the patient, at least for re-RCT, at least you have to be able to tell the patient that whether there will be any, how much will be the success, whether you are going to just try it out. Yeah, that should be told to the patient. Sometimes everyone starts saying we will do a re-RCT, but most of the time they don't are successful. Later they get the tooth extracted. So patients end up just wasting time actually.
Right. So any
Hello,
more
sir.
queries?
Hello,
Yeah,
sir.
good
Good
evening,
afternoon, sir.
sir.
I'm Dr. Ram Prasad from Bangalore.
Yes, sir. Good afternoon, sir.
Yeah, sir. That flossing, we use that thin cord generally
Yes,
advised
yes.
by you.
Yeah.
Now
Yes.
we do get many this one metal flossing with a small tip of this one at the end of this one wherein you can insert between your teeth.
Yeah.
Is it advisable to use them?
Sir, these flossing actually depends upon how much is the interdental space, sir. How much actually the space. We can't, if the interdental space is not that much, you can't use these interdental, even these interdental brushes are available. Actually, you just insert between the teeth to clean. But there should be enough space for the use to use that. Otherwise, if you just, if there is no enough, the interdental space is not that much, you just use these interdental brushes, actually you injure more rather than doing any good. Actually, you'll do the injury will be more. So it depends upon how much interdental space is there, how much the normal flossing should do. That can be done easily, but this interdental pressure you should be very careful.
Okay, sir.
Hello,
Thank you.
sir. Hello, sir. Hello.
Hello, hello, sir. Hello, sir. Please go ahead.
Sir, for extraction of tooth, always the dentist write the mentally retarded patient code. What is to be done in these cases, sir?
What, sir? What they ask? What they write?
The code number is 186, but they ask the mental retarded extraction of the mentally retarded.
No, no.
Rate is
Extraction
more.
for mentally retarded,
No,
even
no,
for
that,
normal
they-
cases.
no, no. You
for-
shouldn't. No, no. You shouldn't allow that. So if the patient is a normal patient, how can you allow the extraction in that category? Yeah, that shouldn't be allowed, sir. Actually, it should be even in for extraction. There are three categories already in the coding. Actually, now normal extraction, surgical extraction, and the impacted extraction of an impacted tooth. I think within the three, you should be giving permission. If you're asking for a mental data, that should be there. Otherwise, you can't give under that category. That is
They
missing.
are normal patients, sir.
Normal. Yeah, you shouldn't give, sir. How can you give for a mental? No, you can't give permission.
Thank you, sir.
Thank you,
Sir,
sir.
what is the
Good evening,
difference
sir.
between
It's Dr. Arshi from CGHS Bangalore. So,
Yes,
with
ma'am.
respect to this extraction thing, only sometimes there is a wisdom tooth extraction which is like a little complicated. Many times the orthodontist will say that it doesn't come under the normal codes where
Yes,
the
ma'am.
tooth is absolutely horizontal or something, and they say a little surgical procedure will have to be done. So, in such cases, what code should we follow, sir?
Ma'am, at the moment, the rate in the CGH is very, very low, ma'am. Actually, they are given just some 200 rupees for an extraction for impacted tooth. Impacted tooth, normally in a private setup, they charge 4,000, 5,000, something like that. It's actually a really complicated procedure. It takes 1.5 hours and a lot of skill from the dentist to remove the tooth. So the rate at the moment is very low. Actually, at the present, from the CGHS rate list, there is already it is mentioned as extraction of impacted tooth. Only that you can give it. I think it's something like 190, 96 rupees, something like that. At the moment, only you can allow for that. But the rate has to be revised here.
But actually, sir, nobody, they don't do it that rate only.
No, no one does. No one does. Patient end up paying more actually. They actually pay more actually. Many of the time there is no need for referral for 196 rupees. Why do you want to get a referral? Actually, that's how they think. Yeah.
So,
Yeah.
but then we cannot propose anything for that if it is genuine. I mean,
Yeah, you should all ask, ma'am. You should all write actually to the director. CGS dental rates are very low. The market rate is very high, ma'am. Actually, you should little bit. It should be serve the patient benefits. Actually, they end up paying more. Actually, and the patient also don't complain because they themselves say these rates are very low. How will a doctor do it? For 196 rupees, you are asking them to do an impacted extraction. Now, even normal extraction we can't do for 196 rupees. This impaction 196 is very, very difficult.
thank
This
you,
is very
sir.
low. Yeah. Thank you.
Hello, sir. Sir, means what is the difference between this complicated extraction and impacted tooth extraction, sir?
Sir, again, there is no much difference. Actually, every impaction extraction is a complicated extraction. I don't know why that category has been included, but almost it's like any posterior or any impacted tooth all come under this. I don't think there is that category. I don't know why it has been mentioned. There should be only a normal extraction and an extraction of an impacted tooth. I don't know why this complicated, and the rates also same. There is no much difference in the rate actually. I don't know why
Yes,
they have
sir.
included. Why it should be revised actually. That even that has to be cleared out.
Yes, okay, sir.
Any more queries from anyone else? So I think, sir, that we are through with our queries.
Yes.
And for information of everyone, we have been recording this session. So I think we'll try and post it to all the additional directors. They can share it with their in charges. All those who have missed the webinar today, they can hear it, and because it's been a very informative session, and I'm sure definitely there is some amount of guidance that you can get from this webinar. We can understand the prescriptions that are coming in from the dental surgeons better, and I'm sure we'll be able to give our patients better advice and explain things to them, because now we are more clear about what things we are going to endorse. So Dr. Manika Vasau, thank you so much for your valuable time, and all the participants, thank you so much for joining in post your dispensary hours.
Thank you.
And I hope we'll have more such webinars in future, more informative webinars. Thank you once again, Dr. Manika Vasau.
Thank you so much. Thank you.
Thank you all.